All right.
So good afternoon, everybody. Thank you so much for joining the third webinar in our Heart Health series in February. My name is Danielle Harmon, and I will be your moderator for today's webinar, where our expert, Dr. Adnan, is going to talk about COVID and how it affects our heart health and what you can see after a diagnosis. So we know that some of the symptoms of COVID can last for months, and the virus can damage our heart, of course, our brain, our lungs, and can give us some increased risk for long-term problems. So we also know that the virus has changed and mutated over the past couple of years. So this presentation is likely to be different than when we talked about it around this time last year. Before we get started, let me tell you a little bit about ARH and go through some housekeeping items. ARH is a nonprofit healthcare system operating 12 hospitals now in southeastern Kentucky and 2 in West Virginia. We are the largest provider of care and the single largest employer in southeastern Kentucky, the third largest private employer in West Virginia. In southern West Virginia. We operate multi-specialty physician practices, home health services, home medical supply stores, physical, occupational, and speech therapy, and retail pharmacies. Our mission is to improve the health and wellness of the people of Appalachia, which is why we have webinars like this one and all of our events that are like it. Some housekeeping again, Q&A will be open throughout the webinar. Please feel comfortable in asking questions in the Q&A or in the chat. And if Dr. Adnan does not answer those throughout the presentation, then we will make sure to do a Q&A at the end, and I can ask those questions for you, and Dr. Adnan will be able to see the Q&A as well. As always, our experts, Dr. Adnan, cannot answer specific medical advice or give referrals on this webinar. So if you need a referral or specific medical advice about your own health, we encourage you to find a doctor that can provide that for you at arh.org. Our speaker today, as I mentioned a couple times, is Dr. Adnan Bhopalwala. Dr. Adnan is a board-certified internal medicine provider and cardiovascular disease, I'll get that out, and he works on our cardiovascular team out of Whitesburg, ARH. Dr. Adnan completed his residency at Michigan State University and his fellowship in cardiovascular disease at the University of Hawaii. He is also our Associate Residency Program Director for Whitesburg, ARH. Welcome, Dr. Adnan. Thank you so much for being here.
Thanks a lot, Ms. Harmon. It's my pleasure, and good afternoon, everyone. Thanks for taking the time out. And what she was talking about, who she was talking about is the good-looking guy in the photo. I'm just someone else. I'm sorry I should have put on a shirt, but guess what? I've been busy taking care of folks with COVID and heart problems. So
we understand. Just happy that you're here. Doesn't matter what you wear.
It's my pleasure, and thank you again for joining. And I'd just like to add to that me, along with my family, my wife Sarah, and we've got 2 boys, have been in Whitesburg for the last 5 years, and it's been a great pleasure, meeting wonderful people and being able to take care of their hearts. And I'll hopefully try to shed some light on my experience last 2 years, especially with COVID. And like we all know, there's a lot of anxiety and sort of anxious things about COVID and heart, and let's try to learn a little bit more about that topic today. So I'll get started with just a little introduction about, like we all know about COVID virus, and COVID-19 started in sort of late 2019 in Wuhan, China. And since then, like we know, has been sort of unprecedented pandemic. This virus, just a few basic things, and then we'll kind of delve into more about what it does to the heart is, first of all, it enters the cells of the body by this M protein or spike protein, right? And that M protein on it, the spikes on the virus, is sort of important because that's what's been mutating. And the virus kind of outsmarts us each time, has mutated in the last 2 years into different forms, the Delta variant, most commonly, more recently, the Omicron. It's that M protein, and that attaches to these ACE2 receptors, the ACE angiotensin converting enzyme 2 receptor, which is present on most of the cells, almost all of the human body, different organs, and that's where the entry point is. Now, after it enters the cells, the way it causes damage, in simple terms, is by 4 mechanisms. One is direct cytotoxic effect, how the cells are affected by the virus itself. The virus enters the cells and causes damage itself. The second is it causes dysregulation of this RAS system and certain hormones which regulate blood pressure and other things and kidney function in the body. The third thing is it causes endothelial cell damage. This is mostly how it causes thromboinflammation, which causes a small microscopic clots and blood clots, and which, as we'll talk about, ends up causing a lot of sort of trouble with blood clots and thromboembolism in the legs and lungs and other tissues and organs. The lastly, and again, very important form where it causes damage is dysregulated immune response. So if it's not the virus really causing direct damage to the body, but the body's immune response to the virus and exaggerated immune response, thereby leading to breathing difficulties, lung problems, ARDS, heart problems, and other things. So once we've looked at that, now the virus, like I said, enters through these ACE receptors into the cell. Now, these receptors are present in all the organs, most of the organs, including brain, lungs, predominantly, heart, pancreas, kidneys, liver, intestines, and which is why you have such a sort of a broad presentation and effect from COVID on the body. So today we're going to be talking about the heart. So the heart is quite a susceptible target for this virus because it is robust blood supply. It's got a lot of blood supply, and it's got a very high levels of these ACE2 receptors, which is targeted by that M protein of the virus, right? So it is also important to remember, though, that the predominant involvement of heart problems, like, very sick, so involvement of the heart is usually seen and restricted to patients, for the most part, who are moderate to severely sick from the virus. In mild cases, for the most part, it is rare to have cardiac problems. Okay. So what can increase your susceptibility to having a more severe illness from COVID? Everyone gets COVID, most people don't get severely ill, and especially now with Omicron, it's more present. It's very contagious, but it's not as ill. People don't get as sick as the Delta variant, for example, or previously. But what happens is, if you have these conditions, if you're older, if you're in a nursing home, you use or long-term care facilities, it's probably because you have some medical illness. People with existing heart conditions like congestive heart failure, coronary artery disease, or blockages already have certain abnormalities like atrial fibrillation or poorly controlled high blood pressure. Patients who have lung disease, COPD, black lung, asthma, patients with diabetes, all of these put you at an increased risk, not of getting COVID, but getting getting sicker with COVID, getting more ill with COVID, ending up in the hospital. Other illnesses that reduce your ability to fight the virus, like immune response from, if you do have cancer or you're on chemotherapy for cancer, if you've had bone marrow transplantation, if you're on immunosuppressive medications for having a transplant before, all of that reduces your ability to fight an infection in general. Same thing for COVID. And then, of course, obesity and smoking. And, there's multiple studies, and we know this as a fact, that it kind of reduces body's ability to fight any kind of infection, especially COVID. You have an increased chance of getting sicker with the virus infection if you're smoking. All right. So now, if you've had these illnesses, and if you do get COVID, and if you do, get a serious illness of COVID, there's chances that the virus, in these cases, can affect the heart in different ways. So predominantly, what I'm going to talk about now is folks who sort of get sick enough to end up in the hospital with the COVID pneumonia, with a sort of overwhelming COVID infection. The oxygen drops, they're really sick, and they end up in the hospital. Then how does it affect the heart, the virus? Okay, so in that case, it can do a few things. Let's see here. Okay, COVID can cause certain abnormal heart rhythms. Now, recently, which we call arrhythmias. So it's not very unique of COVID to cause that. It is any kind of illness, any kind of viral illness or bacterial illness for that matter. When it overwhelms your body's immune response, there's an overwhelming infection, And if you already have a heart condition and if you're susceptible, it can bring out or predispose you to have arrhythmias. And so does COVID does the same thing. And most commonly I've seen, especially with Omicron, because it's so prevalent in the recent couple of months, I've seen a lot of patients who get sick with COVID pneumonia come with a new onset of atrial fibrillation, this abnormal heart rhythm where your heart beats irregular, and have an increased incidence of that atrial fibrillation. Certain less common but possible in severely ill patients with COVID is certain rhythms we call dangerous heart rhythms, we call ventricular tachycardia. And that is not as common as atrial fibrillation, but if seen, can be dangerous for the heart. Certain EKGs abnormalities, which we closely monitor in patients who have COVID and especially who are on medicines for COVID, remdesivir, not in certain other antiviral agents, certain antibodies that we've been using for COVID, and on other antibacterial agents because they're prone to get bacterial infections as well, like azithromycin. We follow a certain number on the EKG very closely. It's called QTC, and monitor for any QTC prolongation, which can predispose your heart to get certain abnormal heart rhythms. And then if we come to the second is heart failure. What is heart failure? Is congestive heart failure is when you're getting more fluid buildup, you're short of breath, you're getting ankle swelling, lower extremity swelling, and unable to breathe, unable to lay down flat. That is retaining a lot of weight and fluid. That is called congestive heart failure. COVID infection and overwhelming infection predisposes you to have more congestive heart failure. Okay, it can affect the heart muscles in different ways, and we'll talk about what is myocarditis in the next few slides, and how myocarditis can put you into heart failure, or even blockages, which we'll talk about, can put you into heart failure. So different things, the way COVID can affect the heart can predispose you to have symptoms of congestive heart failure. And then the next one is coronary artery disease, which is, fatty cholesterol plaque buildup in the arteries of the heart or blockages in the heart. COVID, secondary to by multiple ways, has or can predispose your heart to have blockages. Now, blockages is not in general, it means that each time that you have to rush to the cath lab to put in a stent. There's different kind of coronary artery disease manifestations in patients with COVID. For the most part, we're able to take care of them with medicines, but it is possible that COVID can put you at an increased risk of having a complete blockage as well, wherein you would rush to the ER, to the cath lab, to see if you need a stent to open up a blocked artery. So COVID or severe COVID puts you at an increased risk of having heart attacks. All right. So in general, now this is a very old slide that came up right after COVID. The reason I have this slide is so there's two things. One is COVID can put you, severe COVID, moderate to severe COVID, can put you at an increased risk of having heart attacks, like we already talked about. And those patients are usually in the hospital from COVID illness and have this manifestations of different kind of blockages and heart attack, and we take care of them in different ways. Not always need heart caths. Mostly we can treat it with blood thinners and different medicines. But also, if you don't have COVID, but the reason for this slide is do not ignore your normal symptoms of a heart attack. Because what's happened in the last couple of years is a lot of folks are hesitant to seek medical attention unless they're really sick. Okay, so the emphasis here is if you have predisposing conditions, if you have risk factors like high blood pressure, smoking, hypertension, diabetes, and if you have these classic symptoms, if you think you're having a heart attack, chest pain, pressure, heaviness, something sitting on your chest, you feel jaw pain, sweating, diaphoresis, difficulty breathing, these are common signs or symptoms of having a heart attack. Do not ignore those symptoms, seek medical attention. There's the whole world is now very sort of accustomed to taking care of COVID protocols, getting tested, where there's protocols where we take care of patients with heart attack and stroke just the way we would have if there was no pandemic in this world. All right, now let me just talk a little bit about in detail about these few things which COVID has caused a lot of anxiety and about the heart. One is called myocarditis, right? Where COVID is causing inflammation in the heart muscle. COVID can cause inflammation in the heart muscle in different ways by directly causing damage to the heart muscle, by the immune response, which causes damage to the heart muscle. Myocarditis is an injury of the heart muscle wherein it can get weakened and your heart function can drop. So you can have symptoms of heart failure, that is congestion and fluid buildup in some select patients. So there's a couple of things of COVID myocarditis that you got to remember is it's mostly seen in a severe COVID illness and patients who are admitted with an overwhelming COVID illness. It can affect the heart, like we've been talking about. And one way it can do that is by weakening the heart muscle or myocarditis. Most of these patients are treated with medicines and do better. We get rid of the fluid with medicines. We treat the heart with certain medications to get it stronger, blood thinners, and on some occasions, a select group of patients who get severely ill and end up dying, have this severe weakness of the heart because of myocarditis. Some select patients will need special support. For the lungs, you have the ventilator. For heart, there's certain devices, the mechanical devices, which support the heart and pump temporarily, called ECMO and certain support devices that can be used in the very sick patients who have this very severe illness from a severe case of COVID. The other part about myocarditis is in a younger patient, say young patients, young males especially, athletes, these subgroup of patients are usually, you can have a mild illness but can have inflammation of the heart muscle. Usually there was initially in 2020, we started doing a lot of MRIs on the heart and noticed that a lot of patients with subclinical COVID, that means you don't have an overwhelming infection. Sometimes you don't even know you had it, but you test positive for whatever reason. Those patients got an MRI on the heart. And we saw that there was a lot of inflammation on the heart muscle on the MRI, but not necessarily correlated with symptoms, not necessarily correlated with any bad outcomes. So for the most part, what we've learned by doing MRIs, and there's ongoing process and studies about these, especially younger patients with COVID and concerns for myocarditis, is that the incidence that it does anything big or bad to your heart, it's possible, but it is very rare. Okay, the numbers sort of is under 5 in 100,000 incidents of that, and it's not any higher in younger patients, then you're susceptible. So the way you look at this is COVID puts you at an increased risk of having myocarditis, just like any other virus would do. Any other Epstein-Barr virus, there's different respiratory viruses which cause myocarditis in younger folks. The only thing with COVID is different right now is the prevalence. COVID is kind of so much present everywhere that the chances that you get that with COVID compared to anything else is higher. Okay, so next, let's talk about heart muscle and heart muscle injury. Congestive heart failure, I think we kind of talked about this a little bit already, can be exacerbated by COVID infection by putting extra stress on your heart. Symptoms include worsening shortness of breath, chest tightness, fluid gain, and weight gain. Hospitalized patients with moderate to severe COVID and heart failure exacerbation together do worse. In some studies, heart failure patients with COVID have shown to have an increased death rate or mortality, as we call it, quite a bit higher if you have both of these together, severe COVID and you already have congestive heart failure. What is the link between hypertension and COVID? So let me put this very simply. COVID is a stressful situation on the body. So your body is best fighting that and getting a good outcome and completely getting better if you have everything already in good shape, that your blood pressure is normal, you're healthy, you don't have diabetes, or if you do, it's controlled very well. Same thing for blood pressure. If you do have existing diagnosis of high blood pressure and you're taking your medicine, then make sure to your best chance is if you keep it at best control. Okay, last couple of years, what we've seen is, a lot of patients sort of are worried about coming in and getting regular checks on stuff like basic housekeeping, blood pressure, diabetes, and all this. So that should not be the case. I would encourage everyone to keep on top of their blood pressure, diabetes, annual exams, and use telehealth. If you still sort of are nervous coming into the office, and telehealth options, you can check your blood pressure at home, let your doctor know, and adjust medications accordingly. There's not a single medication which you need to stop or change because of interactions with COVID itself. Initially everything about ACE inhibitors, and it's not true. You continue your same medicines or add medicines if you need, if you have poorly controlled blood pressure. All right. Now let's look at inflammation of the lining of the blood vessels. Now this is sort of a very important and a very difficult situation which COVID can cause. And luckily, this is also reserved in patients who have moderate to severe COVID illness or end up in the hospital, which is a very few patients, right? Most patients have a mild illness. So this blood clots, we usually see it in the hospitalized patients because of an overwhelming sort of immune response, endothelial damage, wherein the blood vessels are more prone because of the infection with COVID to form micro blood clots. These micro and sometimes bigger blood clots as well, but mostly micro blood clots clog up sort of the small capillaries or arteries in your lungs, and thereby the gas exchange is affected and patients cannot breathe and have low oxygen. It can affect in the heart, it can cause stroke, and can affect the brains, and some of that is sort of related to why you have this brain fog later on, and cognitive impairment. And but bigger blood clots can also form and lead, and the dreaded complication of this is where you have this blood clots go to the lung. This is a CT scan image where the black shadow sort of which I've marked with that is a big blood clot sitting in the artery of your lungs. It's called the pulmonary artery, and this is what is called PE, pulmonary embolism. And this can be sort of life-threatening if it is severe. For the most part, we see it, and I've seen it a lot recently, but mostly in hospitalized patients, mostly in patients who have other risk factors to form blood clots as well, like obesity, sedentary lifestyle, poorly controlled diabetes, inflammatory states of other sorts get this. And then the treatment is blood thinners. Initially, we give you IV heparin or shots of Lovenox, and then switch to medicines like warfarin or Coumadin or Eliquis or Xarelto for this pulmonary embolism and DVT. And then you take that for at least 3 to 6 months after the diagnosis of this. Okay. Cardiac arrhythmias and abnormal heart rhythms. I think I'm going to, we talked about atrial fibrillation already, and it's been, I'll say this, that in my experience in the last sort of few months, I've seen a lot of atrial fibrillation, patient with COVID, especially in the hospitalized patients. So this is something to really watch out for, mostly in the hospitalized patients. But even if you've had a mild illness, say you might have a mild COVID illness, but you feel heart palpitations, you feel it flutter, do you have a chance of having atrial fibrillation? It's possible, yes, but rare. I don't want you to be alarmed, but it's better to get it checked out. It's better to do an ultrasound of the heart, make sure the heart functions okay, and do a heart monitoring, wherein we put in the small monitors called event monitors or Holter monitors, and keep an eye on the heart rhythms. If you don't want to come into the office, or if you're under isolation initially, these monitors can be sent to your home with easy setup instructions, and you can put it on yourself and mail it back, and then we can download the information and make sure that you're not having any abnormal heart rhythms. This kind of ties into abnormal heart rhythms from COVID into what is the chances of sudden cardiac death or young patients, especially athletes, if they have COVID, when is it safe to go back to a vigorous exercise and sort of practice and for vigorous training for athletes. So we've seen this quite a bit in the last 2 years, and there's been a lot of studies. A lot of those MRIs have been done in athletes, especially, and then they've seen that the inflammation is there, and there is occurrence of myocarditis and prevalence of that, but it is no more than a normal population cohort, someone who's not got COVID in that age group. So, so it's about the same, and most of the recommendation of returning to practice is basically symptoms, common sense kind of evaluation. If you're an athlete, if you're a young man or woman, and if you have COVID and now you want to return to play or do vigorous exercises, if you're completely asymptomatic, you had a mild flu-like syndrome, you're completely asymptomatic, then usually after that, you do a graded sort of try a little bit of exercise at a time and increase the severity and go back to normal without any check, without getting any tested. But if you have symptoms, you say, 2 weeks out of COVID, you're still having some palpitations, you tried to sort of bike and then you got out of breath, your heart started racing, that's when you would get checked with your PCP, go to a cardiologist, and we would do a basic workup like an EKG, check an ultrasound on the heart, an echocardiogram, and at select patients, we'll get a heart monitor and make sure everything's okay. Some select patients who we're not sure obviously abnormal heart rhythms on a heart monitor, I would send them for further evaluation with a special test called a cardiac MRI, an MRI of the heart. Those we usually, we'll do that in very sub-selected patients. Most people don't, in my recent experience, I'll say with Omicron especially, I've seen a lot of younger folks have a very mild COVID illness and then have had some shortness of breath, some symptoms of palpitations. And I've seen evaluated a lot of these patients, and I've done echocardiograms, we've done EKGs and heart monitors. Have I seen any severe abnormal heart rhythm or illness in the recent, say, 3 months? No, not even a single one in a younger patient age group. But we have to kind of check for it if you are having symptoms. Okay, what symptoms to watch out for once you've had a mild, now we're talking about mild COVID illness. You've been at home, you've recovered from COVID, but if you're still having shortness of breath, chest pain, swelling in the ankles, heart palpitations, not being able to lie flat, you get short of breath, then you sit up and you feel better, waking up at night, shortness of breath, lightheadedness, dizziness. These are some of the symptoms. If you continue to have these, then you're better off getting your heart checked. So consult with a cardiologist. These telehealth and telecardiology is definitely an option. COVID has opened up a lot of avenues, and I've been sort of had the opportunity to be a part of telecardiology, and I see patients at a lot of different hospitals because of cardiology, telecardiology now. I see some patients at Morgan Hospital, McDowell, and different places because of telehealth, and we try our best to help out as much as we can with this service. So that's opened up quite a bit of avenues where you can reach out, and patients can reach out to the cardiologist or to their doctors and kind of get things done. So please feel free to do that. Okay, so now it brings it to me to my sort of this favorite term about what's long COVID and what's, we call them long haulers and long COVID. And so it was interesting when I was kind of researching this myself, and long COVID is a patient coined term. It was first initiated, this term. It's not a medical term, it's a patient coined term, and initially there's one patient in the UK coined this term long COVID, describing her symptoms after a COVID infection, and she initially tweeted about that. And since then, it's sort of went kind of viral, and we have this well-established diagnosis now in a way of patient long haulers or long COVID. It's a patient-created term. It's a constellation of symptoms experienced by patients months after an acute infection. And there may be evidence of multi-organ involvement in some mild ways. which you have persistent symptoms from. A lot of studies have looked at this, when patients have been interviewed on these studies, and more than 200 different symptoms have been reported in patients. 3,000 respondents from 56 countries on this study. It was an international web-based survey. Most patients, 79%, were women. At 6 months, the most common symptom was in 77% of the patients was fatigue and post-exertional malaise and cognitive dysfunction or brain fog. The most common 10 cardiac symptoms were, what is a chest pain, shortness of breath, heart palpitations, exercise intolerance, amongst others. There's different studies that have looked at. This is a follow-up study of a hospitalized patients with COVID in the Lancet. It was a experience of 6 months consequences of COVID-19 and patients discharged from the hospital. About 1,700 patients. Fatigue was in 63%, sleep difficulty in 26%. Most of them got CT chest, and CT chest, there was persistent abnormality on that CAT scan of the chest. And DLCO is your gas diffusion, gas exchange in the lungs. In 56%, that was also abnormal. They saw that it was dependent on your age. Older patients had more abnormalities. Female versus male, women had more abnormalities. And also severity of that initial illness. The more severe the illness, if you've had a prolonged hospitalization, or if you've been on that ventilator, come out of it, the chances that you're going to have persistent symptoms is obviously more. All right. So there's other people. This was an interesting. This is in the UK. I come across this, and they're looking at different studies to look at these organ involvement in patients after COVID. Right, 2 to 3 months from onset of disease, significant proportion of patients had symptoms of fatigue and breathlessness. We've seen that. Now in this study, they scanned everything. They done MRIs of the lungs, MRI of the heart, brain, liver, kidneys, and did see inflammation, that presence of inflammation and abnormalities on the MRI, but not always. In fact, not a great association of that MRI abnormality with symptoms. So it's just kind of there, but it's not causing any big or bad outcomes or symptoms in the patients. Self-reported symptoms of depression and anxiety were common in survivors as well. Okay. Reduced quality of life was also a predominant symptom. So I would say what we know about this long COVID and is still an ongoing research about, does it cause or leave any long-lasting permanent kind of abnormalities, right? That's the big question, and everyone's sort of anxious about that once you have COVID. It seems like for the most part, if you have mild to moderate illness, you do well, and these symptoms last for a while and then get better. In a severely ill patient with COVID initially, these symptoms can last longer. They may be associated with some abnormalities on these MRI scannings, but how it's going to pan out in years to come is still an ongoing investigation. All right, I was going to have a few slides talk about the vaccines and how, especially for the heart. We know my general message for vaccine is very clear in my personal view and my understanding and my reading and the data out there, research out there in the last 1 year, is that vaccines definitely prevent severe illness. It doesn't prevent, nothing prevents you from getting the virus other than just being at home and not getting out at all, and then of course wearing the mask and whatnot. But vaccine can definitely prevent severe illness. So everyone should get vaccinated, will be my message. Now, but there's some, so there's some anxiety about certain vaccines, your mRNA vaccines, Pfizer and Moderna, causing myocarditis. So here's some information on some slides. The COVID vaccination can cause myocarditis, that inflammation of the heart muscle we've been talking about, which COVID itself can cause. The vaccine can cause it, but it is extremely rare. The first dose can cause it, and there's slightly increased chance. The second dose can increase your chance of getting that myocarditis, Moderna vaccine causes it more than Pfizer. Extremely rare, but possible. And we'll look at the numbers, how rare it is. And it's mostly seen in young males. I believe a 15, 16-year-old adolescent males, more than 90% have full functional recovery from that illness, and more than 99% survival. So the deaths have been like, very rare. These are like hundreds of patients, and one death has been reported in Israel and stuff like that. So this condition, this is a paper from Israel when they looked at this vaccine. It's a retrospective study. They said it was 1.5 per 100,000. So that's a very rare case, and fatality was 1 per 9.2 million. So one person in 9.2 million death from that. And then what is the control when you get a vaccine and you get myocarditis? But then you compare it to general public adolescents for 15 to 20 years or whatever, that same age group. You can normally get this myocarditis as well, not from COVID, but other viruses. Young patients have myocarditis, can get from coronavirus, normal viruses that call respiratory illness, Coxsackie virus, Epstein-Barr virus. The other viruses can cause myocarditis. So they compare that to the vaccine-induced myocarditis, right? And they say that it's the same incidence. And in fact, the survival is better, only 1 in 9.2 million death with the COVID vaccine. So in general, what the takeaway from this is, at least in my opinion, that the chances that you get myocarditis in a young man from COVID vaccine is possible, but very rare, and the outcome is really good. But what COVID absolutely does on this slide, when you can see, is what the vaccine does is protects you from getting a severe illness from COVID. What a severe illness from COVID can do is cause a lot of myocarditis, very high incidence of myocarditis, that 1,000 to 4,000, and with bad outcomes if you get severely ill with COVID. So you have bad outcomes, and that can be prevented by being vaccinated, compared to the risk of having muscle damage from the vaccine itself, which is seen in younger folks and very rare. So that's my sort of takeaway on that part. Then the AstraZeneca and other vaccines can cause blood clots, and that's been a thing. But again, my understanding is that adverse effect is also very rare. All right, let's. I think I got some questions myself, and then we can open it to the audience. We'll try to answer some questions. I think most of these I've covered in the topic as well. So say I have a heart condition, and am I at more risk of getting COVID than somebody who does not have a heart condition? So the answer to this question is no. If you have a heart condition, and if someone doesn't have a heart condition, you're at equal risk of getting COVID. But obviously, if you have a heart condition, once you do get COVID, you had an increased risk of having severe illness. And that also, in a way, depends on how well your heart condition is managed in the first place. Like if your diabetes is really well controlled, your blood pressure is normal, and then the risk of getting severe illness from COVID is low. So the answer to this question, only thing that can prevent you from getting COVID, like I said, is wearing a mask and prevention, vaccine. Is the risk of developing severe COVID symptoms similar for all patients with a heart condition, or are there differences? So, there is differences. So let me sort of dwell into this a little bit. Provided that even cardiovascular risk factors such as obesity, chronic kidney disease, hypertension, put you at an increased risk of severe illness and death, some conditions especially put you at an increased risk are if you have a malignancy, if you have had a heart transplant and are on immunosuppressants, and the elderly. So these are the risks which are kind of even worse in terms of having bad outcomes and death from COVID. Individuals with heart conditions such as heart failure, dilated cardiomyopathy, advanced forms of cardiomyopathies, which is weakened heart muscle, patients with some congenital heart problems, these kind of subset of patients are at the highest risk of having bad outcomes or death from a COVID illness. There's no evidence that the virus infects. Say sometimes you have a defibrillator and patients are worried, can my defibrillator or pacemaker be infected with COVID? So far, there's no infection, no evidence of that. There's no evidence that it can cause an endocarditis on the heart valves or anything of that sort. I have atrial fibrillation. Am I at a greater risk of getting the coronavirus infection? Atrial fibrillation by itself does not increase the risk of infection. Nevertheless, many atrial fibrillation patients are older. So why you have AFib in the first place sort of adds to that, right? AFib is normally seen in older patients, patients who have diabetes, hypertension, smoking, have atrial fibrillation more commonly than others. So those risk factors can put you at an increased risk of having severe COVID illness and not AFib per se. So what I've seen, like I said, AFib has been more common recently in those kind of sect of patients who already have some risk factors, then get COVID and the stress from COVID, and heart goes out into AFib. Okay, I have read that the coronavirus can cause heart problems such as heart attack or arrhythmias. So I think we've sort of alluded to this a little bit. So I'll kind of say yes, you know, if you have severe illness for COVID, definitely there's an increased chance that you can get all sorts of heart problems. This is mostly seen in patients in the hospital with COVID, congestive heart failure, blockages, blood clots, abnormal heart rhythms leading to death. Are cardiac patients who also have diabetes and hypertension at greater risk? You know, we've talked about this, and this is, I'm sorry, kind of a redundant slide here, so I'll keep going. There are reports that COVID-19 may induce myocarditis or pericarditis. Now, if you have had myocarditis previously, are you more vulnerable to contracting it a second time? So there's no evidence that individuals who suffered from myocarditis or pericarditis in the past had a higher risk of developing the same complication with COVID-19. It is recognized that some cases of myocarditis have a relapsing and remitting course, and that is sort of independent of COVID-19. Okay. Are people with heart disease more likely to die of COVID than those without? So far, the short answer to that is yes. Older age and prevalence of underlying conditions, including heart conditions, have an increased risk for death. Nevertheless, it is important to emphasize that most patients, even those with underlying heart disease, have had mild infections and have fully recovered. So that's a very important point. All right, I think that concludes my presentation, Danielle. I think we can open it up to questions. Yeah.
Absolutely, thank you so much. It looks like we have a couple in Q&A, so I'll go ahead and get those, and then we can move backwards. So the first one is there a way to reduce cholesterol with natural supplements instead of statins that cause bone and muscle pain?
Yes, I would say I'm trying that myself. Exercise, weight loss, eating healthy, avoid red meat, and as much as white meat, you know, and then fish oil has some benefits, but diet and exercise is the only way to reduce your cholesterol. And if you're unable to do that, then in a way with sort of the other supplements, is if that's your question, then some of them do help, but not to a very big extent. In my experience, if you've had blockages in your heart, then we have certain goals where we need your cholesterol to be. The LDL cholesterol needs to be less than 70, say if you've had a blockage before. So I think the answer in that case will be no. We have to use medicines to get it below 70, in my experience. If the statins cause muscle pains and you're intolerant to statins, there's 3 newer medications now, 3 different classes of medications, which we can use to lower the cholesterol in patients who cannot take statins.
Thank you. The next question is right branch bundle block associated with COVID? I have no idea what that means, so you'll have to explain.
Right bundle branch block, I think you got that right,
okay.
Is, I believe, 15 to 20% of the population is born with a right bundle branch block. It's not a pathologic phenomenon. It's not an abnormality. folks, 20% of the population have it. There's no association of that and COVID in my understanding.
Okay, thank you. Perfect. So that answers both of those questions that were there. Let me see if we have any chat. Vicky, thank you. Vicky says, thank you for the presentation. Very interesting. You're very welcome. So we had a couple questions that had come through beforehand, but I think you were very thorough and answered most of them. So the first one was about athletes, which you addressed, and myocarditis. Do you also address the common differences in Omicron and heart disease in the previous variants, which sounds like it's just less severe, like most of the symptoms that we see, which is a positive thing, and we hope we keep moving in that direction?
Yes, so my understanding of Omicron is just like, and the heart, let me not just answer it again, just for the heart, is coronavirus is no different in causing anything to your body than so many different viruses we know, okay? The only problem with coronavirus right now is that there's a lot of it in the world. It's a pandemic compared to other viruses, right? So it does the exact same thing which another virus can do, but it's just the prevalence is so high. The prevalence, that means it's there so much that your risk of getting it is so much higher than getting another virus. And Omicron especially seems to be that it is milder, but it is more contagious. So even if it is mild, if it is more contagious, a lot of patients still end up getting very sick with it. So that's the answer to that.
Thank you. Next, is there a connection between Omicron and AFib? And you may have answered this already.
Because the same thing, there's so much Omicron, there's so many people who've got positive. That's why I think it's just a sort of that ratio of it. It's not particularly anything new about Omicron. It's just that so many patients who are predisposed to get AFib anyway are getting infected and come and present with AFib.
Mm-hmm. We have another question in Q&A that says, you mentioned 3 medicines to treat high cholesterol. What are they?
You gotta come see me in the office for that. No, it's good. All right, let me answer that just for you. It is ezetimibe. Zetia is a medication which we use in some patients, and there's some injectable medications that can be used. One is which we call PCSK9 inhibitors. These are injectables you take twice a month, every 2 weeks, and have robust lowering of your bad cholesterol with those medicines. But insurance will cover for those medicines only if you are unable to take your statins.
Thank you. Next question is, have there been a lot of incidents of increased heart rate after a COVID vaccine?
Increased heart rate after a COVID vaccine, not sure, but I don't think so. The only way, sort of the heart rate, if you have a sort of adverse reaction to the vaccine, a lot of folks have sort of pain and adverse reactions at the site, and your heart can respond by going faster. But the overall incidence of adverse reaction to the vaccine itself is very low.
Mm-hmm. I'm sure that anxiety of needles and vaccines in general can cause that.
I think it's in general. Yeah, I agree with that.
Yeah. So the next question is, can diet and exercise help control genetic high blood pressure, or do those with genetic high blood pressure always need to take blood pressure medication?
Diet and exercise sort of always helps. It's very irrespective of what is causing your blood pressure to be high. Smoking cessation, diet, and weight loss is very clearly shown in multiple studies to drop your blood pressure. But yes, if you have certain conditions that predispose you to have high blood pressure, then sometimes there's an increased chance that you will require medications too, in addition to diet and exercise.
Perfect, thank you. The last question that I have is that you mentioned telehealth visits that we now have for cardio, which is wonderful that we're able to offer that service. Can you talk a little bit about how our patients would be able to receive those telemed visits? Do they need to go in office first and have a referral for telemed, or how does that work?
I believe, at ARH, we now have an option to have, your My Chart, where patients can log into their charts and have access to their own records. Via that My Chart, you're able to request for a telehealth visit as well. And besides that, all you need to do, if you call the clinic, you don't need to come to the clinic in person. You can call and request a telehealth visit. We can do it in different ways. If you have a video conferencing capability, like a FaceTime on your iPhone or Zoom, we can do it that way. But I've been able to help patients with just a phone call visit as well. And that's sort of not our preference. It would be better evaluation with a video capability, but you can just call and request for a telehealth visit.
That's wonderful. We're doing our community health needs assessments right now, and that's one of the answers we're having a lot in our focus groups, is that we ask the question, how has COVID affected your life, positive and negative? And that's always a positive. Everyone seems to really have taken to telehealth. So
yeah,
very positive. So thank you so much, Dr. Adnan. I don't see any more questions, but I do see, if you want to check out the chat, people are very happy with the presentation, and thank you for it. So we are very appreciative.
It's my pleasure. Anytime. My pleasure.
Thank you for being here. So I think with that, we will end our webinar for today. I just wanted to remind everyone that this is an incentivized webinar series. So if you are here today, then your email address and your name, when you registered, have been put into our drawing. So every webinar that we have, we'll have a drawing for a HelloFresh card. And then if you attend all 4 webinars in this series in February, then you'll be entered to win a mirror, which is the home gym. It's pretty cool, and a 1-year subscription as well. So please let me know if you think that you did not give me your name and email address when you registered. You can shoot me an email. It's dharman@arh.org, and I can get that fixed for you. And with that, I will end our webinar for today. Thank you so much, Dr. Adnan, and everyone else. We hope to see you on Thursday for our next webinar about depression and how that affects your heart. Thank you so much, and happy heart.
Thank you, Daniel. Bye.
Thank you. Bye-bye.